Malignant atherosclerosis in renal failure. Chronic kidney disease is associated with a high incidence of cardiovascular events resulting from myocardial infarction, stroke, and peripheral vascular disease. The atherosclerosis that is responsible for these events is more extensive and appears more rapidly progressive in patients with renal disease. Today, we know that the development of atherosclerosis is the result of a dysfunctional endothelium and an inflammatory response within the arterial wall. This presentation will discuss the mechanisms that result in the profound endothelial dysfunction observed in the patient with chronic kidney disease. The endothelium provides the interface between the circulating elements and the arterial wall. Nitric oxide released from the endothelium is a key player in the maintenance of vascular homeostasis. Nitric oxide can be considered as an anti-atherogenic molecule. Nitric oxide vasodilates the vessels, prevents thrombosis, reduces inflammation, decreases oxidative stress, and limits vascular smooth muscle migration. As a result, nitric oxide maintains the health of the arterial wall, thereby preventing the sequence of events that lead to the development of atherosclerosis and the complications consequent to thrombotic occlusion of the artery. The endothelial cell wall has invaginations called caveolae. Within the caveolae lies the enzyme enos, an enzyme that catalyzes the production of nitric oxide from its precursor molecule, L-arginine. This enzyme is coupled to its cofactor tetrahydrobiopterin, or BH4. Nitric oxide synthetase is highly dependent upon tetrahydrobiopterin, or BH4, to maintain its structure in an active dimeric form. BH4 holds the dimeric form of enos together, such that it can now actively catalyze the production of nitric oxide from the precursor molecule, L-arginine. When the amount of tetrahydrobiopterin present is inadequate, the nitric oxide synthetase enzyme is not coupled, and instead of producing nitric oxide, the uncoupled enos enzyme now makes free harmful oxygen-free radicals, or reactive oxygen species. Nitric oxide synthesis can also be modulated by a regulator called caveolin that binds to nitric oxide synthetase and inactivates the enzyme. Consequently, when caveolin is increased, nitric oxide bioavailability is reduced. Atherosclerosis is a widespread systemic disease. In patients with renal dysfunction, the extent and severity of atherosclerosis is exaggerated and associated with a systemic inflammatory process, which is an important component in the development of the disease. Patients with renal disease have an increased prevalence of the traditional risk factors for atherosclerosis, such as hypertension, diabetes, dyslipidemia, and hyperhomocystinemia, all of which result in endothelial dysfunction. The combined effects of the coexisting traditional risk factors and the effect of renal disease and uremia result in conditions that promote endothelial cell activation and consequent dysfunction, as well as promoting a vigorous vascular inflammatory state. Endothelial dysfunction is prominent in patients with renal disease and is associated with decreased nitric oxide bioavailability, an increase in caveolin which further decreases nitric oxide synthase availability, and a deficiency of tetrahydrobiopterin or BH4 that decreases the ability of enos to be coupled and consequently increases free radical production. Angiotensin II and endothelin are increased, which are powerful vasoconstrictors released from the endothelial cell and further the formation of reactive oxygen species. The increased availability of reactive oxygen species results in the oxidation of LDL, which is a potent stimulus for a further increase in the inflammatory response. The activated endothelial cells express several inflammatory markers, primarily IL-6, TNF-alpha, ICAM, VCAM, and MCP1. Strong evidence links the association between the development of atherosclerosis and increased levels of C-reactive protein, which may not be only a marker of atherosclerosis, but also play an important role in its development. Endothelial cell activation and vascular inflammation are also associated with enhanced coagulation and greater thrombus stability. There is an upregulation of endothelial cell receptors that bind oxidized LDL, such as LOX1 and CD40, and CD40 ligand, as well as an increase in advanced glycosylation end products and their receptors. And lastly, a mechanism that is perhaps distinct to vascular damage in renal dysfunction is the calcium phosphate parathyroid hormone interaction, which results in pronounced vascular calcification. Multiple mechanisms of endothelial dysfunction result in the malignant atherosclerosis observed in the patient with chronic kidney disease and renal dysfunction. Systemic vascular inflammation also plays a pivotal role in the development of disease and will be discussed in the next